So the tradition of this conference is that there is one person who you say the word neuroendocrine tumor, you look it up in Facebook, you look it up in Webster's dictionary, and you see one man's photograph. And that's Dr. Richard Warner from Mount Sinai in New York City. So without to-do, Dr. Richard Warner is going to talk about the basics. And we're going to start at the beginning, and each of the speakers will probably, like myself, give you a little bit of a refresher course as we go through. But Dr. Warner is the king, and he's the guy who can take us from the beginning to the state of the art. Richard, it's a real pleasure.
Thank you, Eugene. Good morning, everybody. It is a pleasure to see so many familiar faces and also so many new ones. We have an awful lot to say, and you're going to hear a lot as this session, as this meeting goes on. And it's really going to give you a full panorama of the landscape of carcinoid and neuroendocrine tumors. You are, the audience, a very heterogeneous mixed group. Some of you are ingenues, real newbies, beginners in terms of your journey along with your neuroendocrine tumor disease, but you're not schooled in medical or scientific areas, and some of the very basic things, the terms, are in themselves not something with which you're familiar. Yet there are others here, many who, because of the dint of their profession or training, or else through the passage of time, have become very knowledgeable and schooled in the details of this disease. And so you know as much, or in some instances, perhaps more than your doctors. So some of you will not be familiar with even the simplest terms or words. Others, if I take time to explain, are going to really feel slighted. And so what I want to emphasize is make notes of what you would wish to ask as a question later on and during the question answer period. And don't be shy about asking the simplest things. What does mitosis mean? What does necrosis? What is apoptosis? Those and many other terms we're going to use. If you don't understand them, you really won't be able to get the benefit of all that's being said. The carcinoid tumor got its name because it's cancer-like, but not identical. So that, like in science fiction, humanoid means like a human, but not identical, yet not something really different. And carcinoid is sort of an in-between the true, really aggressive, dangerous, and more fastly growing tumors, and those that are totally benign and don't spread and don't have lethal potential. And carcinoids in between. But almost all carcinoids and other neuroendocrine tumors in this family of tumors have the potential to become truly malignant. And so we have to bear that in mind. I hate it when I get a pathology report that says benign carcinoid. That's not something that can really be said easily or correctly, and you should not accept that. That's the first consideration. Secondly, what do we see here in this picture? We see a person walking a bunch of dogs, but they're all different, yet they're all canines that belong to the family of canines. And similarly, though there are many breeds and varieties of, they're all canines. Similarly, to clarify what the difference is, which I've often been asked, between neuroendocrine tumors and carcinoid. Neuroendocrine tumors are the family to which carcinoid belong, just like canines is the family to which all dogs belong. And like the different breeds of dogs. There is a variety of different neuroendocrine tumors, of which carcinoid happens to be the commonest. We'll mention a word or two about some of the others, which are rarer, but nonetheless are very important, especially if that's something you have. And here you see a listing of the frequency with which these different tumors occur. I won't dwell on it extensively, but just to point out that about 75% of all neuroendocrine tumors are carcinoids. And as you will see, carcinoids can arise in a wide variety of areas in the body, although they're most common in the intestinal tract, especially the small bowel, but they're becoming increasingly frequently diagnosed in the rectum. And also the smaller percentage, actually 28% of all carcinoids arise in the lung. And then the leftover 25%, or 1/4 of all neuroendocrine tumors, most of which, but not all, arise in the pancreas, so in the so-called islet cells. And these constitute a wide variety. Some have no function. They don't make any hormones or chemicals, and but still can grow and spread. And the others have specific function depending on the type of cells from which they arise. And they're named after what substances they make. Like gastrinoma makes gastrin and causes certain symptoms of its own. Insulinoma makes insulin and causes symptoms of too much insulin, and so on. These tumors are increasingly rare, but nevertheless very important. And here we just have a listing of these different types of tumors and what symptoms they might cause. And this again lists the distribution or the sites in which these of these different tumors. As you can see, there are a number of observations about these tumors and statistics that have been collected. I can't see very well from here again. I'm thinking that the slide should be self-explanatory. Maybe we can get a little help. How do you get that working? All right.
Couple of technical difficulties this morning. Everything works well until we get that point. So what I'm going to do is turn the screen a little bit. Not so that
But even that, the monitor should be faster. You can't see what we got down low. But I'll turn this. There we go. Okay, now we're gonna succeed. All right, we're back to the slide showing the different types of gastroenteropancreatic nets, GIP nets. And you see carcinoid at the top, which makes serotonin and some other substances called tachykinins, bradykinins, and these produce the carcinoid syndrome. But that syndrome does not occur in all patients with carcinoid, in maybe at the most about 30 or 40%, but more often not that many, and particularly, however, with those that arise in the small intestine. And we'll devote a little more attention to that later. And you see the listing of some of the major pancreatic, other neuroendocrine nets, and the substances that they produce and the symptoms produced. We won't take up time dwelling on that. If you have one of these, you can see what substances it makes and the symptoms that would occur as a consequence. And the distribution we alluded to before, showing that most of the carcinoids arise in the gastrointestinal system, or secondly in the lung. 2% of all gastroenteropancreatic malignancies are neuroendocrine tumors. Only 2%. All the others, the common pancreas cancers, stomach cancers, colorectal cancers, constitute the vast majority of such tumors. Only a small percentage of these lesions are carcinoids or neuroendocrine. That's why they're called orphan disease, orphan tumors. And these can be functioning or non-functioning, a term you may hear. Functioning means they produce substances that are making symptoms, so like serotonin, for example. But not all of them are functioning, not by no means at all. And some that aren't apparently functioning, if they spread and grow bigger, may become functioning because the larger volume of tumors is enough to make enough hormones that it would produce to cause symptoms. Microscopically, and this is very important, microscopically on biopsy, they all look the same, very close. It's very difficult, for example, to differentiate by standard appearance and standard staining between, say, a gastronoma and a carcinoid. Special stains, special testing is necessary, and you'll hear a little more about that in a few moments. Also, when these tumors are first diagnosed, where they arise is very important. Those that arise most of the time from the digestive tract that differ. For example, those in the extended, and this is very important and one of the areas that is receiving great attention to make an earlier diagnosis. Those in the lung are about half and half. They will have some, at least regional lymph nodes involved at the time they're first diagnosed. Now, you'll hear more from the pathology lecture that will follow, but there are criteria that must be met for what we consider a minimally adequate pathology report on a biopsy. It has to cite where the tissue came from. It has to indicate whether the sample is a metastasis or the primary tumor. It has to be graded. That means its degree of aggressiveness has to be stated. And the way of doing that nowadays is considered not only the differentiation of the tumor, that means how much it resembles the tissue from which the cell type from which it originated, and how much the proliferation index is, that so-called Ki-67 or MIB-1 staining properties. And then also we want to measure stain for chromogranin, synaptophysin, and some statement has to be stated as to the extent of the tumor so it can be staged. You'll hear more about this as the conference goes on. Looking at the degrees of cell growth, there will be a mitosis count, and you see circled the mitosis, meaning the cells which are in the process of dividing and replicating, multiplying, or in other words, the more of these that are undergoing mitosis, the faster the tumor is growing. So the mitosis rate is very important. Ki-67 is a substance in the nucleus of the cell which undergoes a change as the cell is preparing or undergoing replication, and this will stain specifically. And so doing that type of stain and looking at it under the microscope will help tell what the rate of growth or aggressiveness or so-called proliferation index of the cell is. No pathology report is adequate without that type of stain. It's not good enough just to get a path report that says carcinoid or even just neuroendocrine tumor. Again, addressing the question of differentiation, a well-differentiated cell or tumor cell will look like the tumor cell or the cell type from which it originated. And here we see a brick wall, and you might say it's well differentiated. Every brick looks like every other brick. They're all the same. And here's a moderately differentiated brick wall in which the cells are essentially the same size, the bricks, but they differ a bit in their coloration. So they're sort of not quite all identical, but they're very similar. And then here's a poorly differentiated stone wall. The stones are all different colors and sizes and shapes, and so they don't represent any one stone that they take after. And similarly, a poorly differentiated tumor is going to have different cells, different sizes, different shapes, and that speaks for a more aggressive growth. So the differentiation is a very important feature to be described. And here is a segment of intestine that's been removed and sliced open long ways, and you can see the folds of the lining, the mucus lining of the intestine, and several little lumps, polyps, nodules, if you wish. And these were multiple small carcinoid tumors. And as you'll see on the next slide, this is a bit of a magnification of one of those nodules on cross-section. And I want to point to you, there are layers to the intestine. And here you see a thin layer running over this yellowish mass in the center. And that's the mucosa, the lining. And these tumors originate at the base of that lining. But then deep to that, in the middle of this piece of intestine, is a darker layer. That's the muscular layer. And if you look closely, you can see some strands of the yellow tumor infiltrating through that layer and going into the tissue just beyond which is called the serosa. The serosa is the outer coating of the intestine, and even a little bit is worked its way through the serosa. So this small tumor, which in this instance no more than a centimeter or about a third of an inch in diameter, has already extended through the full thickness of the intestinal wall, taking a little snip of it from the surface from inside the intestine with an endoscope is not going to remove it. It's only going to get a sample. This has to be removed in toto with the whole segment of the intestine in which it arises. As far as symptoms with which these tumors present, and we're talking now about the commonest, namely the small intestinal carcinoids, abdominal pain, it may be for in and out, on and off for years, and it's not always diagnosed right away because for every tummy ache, you're not submitted for a CAT scan or for complicated X-rays or things like that, and it may often be considered, especially when it gets better by itself and doesn't occur but once every couple of months, it may be considered irritable bowel or just anxiety and nervous. Or then if you begin to get some diarrhea, maybe it'll be thought to be inflammatory bowel disease like ulcerative colitis or Crohn's disease. Other symptoms may be severe pain from time to time, which are transient episodes of obstruction. Again, that's often passed off and just watched, and then finally gets worse enough, and then an operation ensues or X-rays and shows that there's obstruction due to the tumor. Less commonly, but common enough that it occurs in a recognized frequency, is bleeding. The surface of the tumor may become raw, ulcerated, and bleed. So it can be one of the many causes of bleeding in the intestine and has to be considered. Then, when it becomes more far advanced, a mass, a lump, may be felt by the patient themselves or by the doctor examining, and that's a tumor that has either arisen, maybe even a metastasis from the tumor. And then in a certain percentage of cases, as I said, less than 40%, the carcinoid syndrome, the main features of which are diarrhea and facial flushing, may occur and be the presenting cause. Well, flushing, getting red in the face, is very common, and it's not unique just for carcinoid. It comes from things as simple as menopause or embarrassment, or some people have it as a constitutional feature. They always get red in the face when they exercise. And then there's also rosacea, which is a dermatologic condition, the origin of which is not really clear, and it's often a wastebasket into which flushing is cast, and really is due to many other things. So there are many diseases that can cause flushing. The outstanding feature of the carcinoid flush is that it's dry, that you don't sweat, it's not wet, there's not dampness, and so on. So any flush that's with a great deal of sweating is not carcinoid flush. Finally, the disease may be found purely coincidentally. Person gets a gallbladder operation for gallstones, or what was thought to be gallstones, and lo and behold, it wasn't. There's carcinoid there, or carcinoid coincidentally. The same thing holds for carcinoids of the lung. They're often coincidental findings. You're going to have a surgery for anything, any other cause, and you have a preoperative chest X-ray, and lo and behold, there's a little round nodule in your lung. So the case is closed off, and the workup takes place, and it's found to be carcinoid. That's not an unusual finding. We may also have recurrent episodes of infection, pneumonia, or chronic bronchitis, but it always occurs in the same part of the lung, and that's due to the tumor that's obstructing the bronchus, and the secretions collect behind it. We may have coughing, producing some blood, and that can be from carcinoid in the lung, or maybe a dry chronic cough also may be carcinoid, Or maybe it first presents with distant metastases, a lump in the liver, or a mass is found on a coincidental CAT scan or sonogram that is done for various other purposes. And then finally, we may have a syndrome such as the carcinoid syndrome or other types of syndromes that are produced by hormones that the tumor may make. The lung carcinoids have the potential for making more different substances than do those from the digestive tract. And one of the most interesting or unusual syndromes is the Cushing syndrome, which is due to excessive production of a hormone called ACTH that stimulates the adrenals to make excess of cortisone, and that causes diarrhea or weight loss, obesity, hypertension, and a red flush of its own. Now here are listed the features of carcinoid syndrome. They're divided arbitrarily into major and minor features, and they need not all be present. But usually the hallmark is flushing, getting hot and red in the face. And I'll show you a picture of a gentleman who gave me his permission to show his picture, who had very early carcinoid syndrome, and you will see what I've been talking about. Diarrhea, which may be painless and may be intermittent, and is also a frequent symptom of carcinoid. Pellagra, which is a vitamin deficiency disease, deficiency of vitamin B3, niacin, is because if you have a serotonin-producing tumor, it gobbles up all the tryptophan in the blood, which is the precursor, the substance from which B3 is made, and so you become deficient in that, and you get this disease, pellagra, which is not well recognized in our society because we have foods that are loaded with extra vitamins. Every loaf of bread has vitamins of different types, all cereals and so forth, including B3. But in people who are starved or don't eat well, or in third world countries, deficiency is more common, and if carcinoid occurs, then pellagra may occur, and pellagra actually is present, at least in a subclinical way, in 1/3 of all patients presenting with carcinoid syndrome. And the main features of pellagra are like carcinoid diarrhea, and who needs that on top of the carcinoid syndrome diarrhea? Also, it's mental changes, emotional changes, depression or hallucinations, etc., and a skin rash, pigmentation, and changes, especially in parts of the skin that are exposed to the sun. So part of our treatment of all carcinoid syndrome patients is simply to give extra niacin, and it's done prophylactically. It's easy just to take an extra dose of niacin in many of the multiple vitamin preparations. Venous telangiectasia, little spiders on your nose or on your cheeks, these are characteristic of carcinoid syndrome and become worse as the time progresses. Heart manifestations used to be very common and then improved, and now are beginning to, with carcinoid patients living much longer, are beginning to be seen again more frequently. Apparently the serotonin has an effect causing fibrosis, scarring on the surface of certain of the heart valves, particularly on the right side of the heart. And this causes impairment in the heart action, and we get carcinoid valve heart disease. And we've been treating that when it's far advanced by replacing the valve, and it works wonderfully. Only thing is, you've got to control the blood serotonin levels, or if it's a biological valve that's replaced, the disease may recur. If you use a mechanical valve, a metal or plastic valve, then you won't have recurrent disease, but you've got to be on anticoagulants the rest of your life. And if you're going to get chemotherapy or have more surgery, which is very frequent for this disease, then you're going to have problems with the anticoagulation. Finally, most patients have an enlarged liver because metastases are present, and that is considered the usual part of the syndrome. There are minor features. Peptic ulcer is present in 1/3 of the cases. Very low serum albumin, again because of the cannibalizing of the tryptophan, an essential amino acid, by the serotonin production. Undue wasting of muscles, atrophy of muscles, joint pains, a scarring in the muscles, and then in an atypical case of unusual type of chemistry, a very brownish discoloration of the skin and swelling of the feet occur. And finally, it is very frequently encountered that blood sugar levels, glucose levels, are increased in carcinoid syndrome. And this also occurs with chronic octreotide treatment. And nowadays, it's also seen with administration of some of the mTOR inhibitors like Afinitor, everolimus. And here's a gentleman with nice rosy cheeks. And this is actually an early carcinoid flush. And I thank him for his voluntarily allowing his picture to be shown. Not every red face is carcinoid, I emphasize, but nonetheless it has to be suspected. Now, there is such a thing as carcinoid crisis, and it deserves some consideration. This is a group of symptoms of severe carcinoid syndrome, which can be precipitated by a variety of things, particularly stressful events, things that cause release of adrenaline-like substances in the body that trigger off the release of the chemicals from carcinoid tumor. Most usually, very severe fall in blood pressure occurs. Rarely it can be a spike in blood pressure. And this can occur at the beginning of anesthesia or surgery or some stressful life event, and the person can go into shock. The heart beats very rapidly, tachycardia, they become weak, they become short of breath, they may get wheezing due to bronchospasm, like asthma. And if they're given the usual adrenergic, adrenaline-like substances to help the low blood pressure, it worsens the situation. And this is reason why every carcinoid patient, even if they don't have a known syndrome, before undergoing surgery, should be given a prophylactic injection of octreotide, or even have a continuous intravenous infusion going on with that substance during the surgery. As you can see, calcium infusion can also provoke this syndrome, this crisis. I'm not going to dwell a long time on this slide because we can give a lecture on it itself. It just shows the different volumes and types of fluids that enter into the digestive tract and underlie the different types of diarrhea. Starting with what the fluid you take by mouth and going on to the volume of fluid that's saliva, the fluid that is produced by the stomach, digestive juices, acid, the intestinal secretions, the biliary secretions, the absorption from the colon of the fluid. Actually, at least 8 liters of fluid are presented in the digestive tract, and yet in the course of a day, and yet only 200 milliliters end up in the normal stool output, and that's because of reabsorption. Many things can promote diarrhea, loose and frequent stools, such as simply a surgery in which the intestine is shortened, so there's not an opportunity to reabsorb. There may be toxic materials, say like cholera. That infection provides a toxin that paralyzes the absorption of secretions. So voluminous fluid volumes are excreted and so on. Serotonin and some of the other products of carcinoid will impair the absorption or the secretion, and this balance between fluid production and reabsorption, and hence can account for the diarrhea. And similarly, in one of the well-known neuroendocrine tumor syndromes called VIPoma, VIP, it's a substance that's produced by certain cells in the pancreas, and when they overgrow in forming a VIPoma, then we get an excess of VIP, which overstimulates the intestine, and we get a voluminous diarrhea. So there are many causes and many mechanisms. And some of these diarrheas have nothing to do with eating, that you have it whether you eat or don't eat. And this is important. Certain types of diarrhea occur even at night when you're sleeping. And that's important for us to know, because that helps give a tip-off that it's what we call secretory diarrhea. It's due to an impairment in the secretion and reabsorption of these fluids. Now, how is carcinoid diagnosed? Well, the first thing that's important is it's got to be suspected. If you don't think of it, you don't make the diagnosis. So the motto, if you don't suspect it, you can't detect it. And that's also why the zebra is the icon for carcinoid and neuroendocrine tumors. When you hear hoofbeats, you think of horses. So when a doctor sees somebody with a common symptom like abdominal pain or diarrhea, he thinks of the common causes, but you got to think outside the box. And instead of a herd of horses, there might be a zebra in there. So that's why the icon. At any rate, once it's suspected, then you can do things to diagnose. You can test for the blood markers or the urine markers, the chemistries, the substances that are produced by these tumors, and they should be increased. And we'll give you a list of those in a moment. Then we can do imaging, X-rays, CAT scans, MRIs, etc., or even endoscopies to look and see directly, and that will help. And then finally, to clinch the diagnosis, a biopsy. It's not really proven until you have a tissue diagnosis. And so those are the four columns that support the diagnosis. Here for markers, the classic one is urine 5-HIAA, standing for 5-hydroxyendolacetic acid, which is the traditional way of measuring, and that requires 24 hours of urine and on a diet that doesn't contain foods that have lots of serotonin in them. And even then, the value will not be increased in about 1/4 to 1/3 of the cases. And so you will, if you rely on that alone, you'll miss some cases. Secondly, blood serotonin is very good too. It's even in cases that don't have carcinoid syndrome, it is often slightly elevated. So careful measurements will help. Then we measure chromogranin A, which is another co-produced substance, but it doesn't cause symptoms. However, it's very often elevated. And we like to do all of these substances, not just one, because sometimes only one of them is elevated. Now, there are other markers or chemical products. Well, first, we'll come back to that in a moment. Regarding chromogranin A, which is very popular to be tested for testing, there are many things that can throw off the value and has to be considered. First of all, it has to be done fasting, as do these other markers. If there's kidney impairment, if there's liver impairment, that will cause an elevated value. If you're on a PPI, proton pump inhibitor, one of the drugs that are used so commonly to reduce gastric acid, like Protonex and Protonix, Prevacid, the Nexium, just to name a few. If a person's on those drugs, that'll be an elevated chromogranin A, and you can't just stop it overnight. It's got to be stopped a long time ahead. Sometimes if you've been on them for a long time, I find you have to stop it for at least a month. And if it's necessary for stomach symptoms, that's not always easy to do. If there's surgery and part of the stomach called the antrum is still left in, that can cause elevation. If you have gastrinoma and the Zollinger-Ellison syndrome, or if you have atrophic gastritis, as in accompanying pernicious anemia, for example, you get an elevated serum gastrin. If you have inflammatory bowel disease, like very active Crohn's disease, that can cause an elevation. And finally, if you're under great physical stress, for example, I've seen some people who run marathons and then have some diarrhea afterwards, and their chromogranin A is measured and it's high. So, wow, everybody's afraid they have carcinoid, but it's the result of the physical stress. Now, some of the other markers, neuron-specific enolase is not specific for carcinoid. Substance P is relied upon often and is helpful. Pancreatic polypeptide, another substance which is sometimes elevated, particularly with pancreatic neuroendocrine tumors. Pancreastatin, which is a product of chromogranin A, is one that I like very much, which not only is often elevated, but also the magnitude of its elevation correlates with the prognosis for the disease. Neurokinin A is another one, subunit of human chorionic gonadotropin, is infrequently elevated. And finally, CEA, carcinoembryonic antigen, which is so important in measuring or determining the presence of metastases for ordinary colorectal cancer or breast or many other types of malignancy, is almost never elevated in neuroendocrine tumors. And when it is, it carries a very serious bad prognosis or indicates the coexistence of another type of tumor, which occurs in about anywhere from 15 to 25% of all carcinoids. You get a second cancer at some time. Now back to standard imaging. Regular plain X-ray, a chest film shows a lump in the lung. A CAT scan, an MRI. You'll hear more about these as the conference goes on. Sonography, ultrasound, and we do it internally now with a scope, an endoscope that can have the probe that does the ultrasonography internally, so it's very close to the organs that are being studied. We can do isotope bone scans that are helpful, and Octrio scan, which is in the United States the gold standard. You'll hear more about that. It's going to be eventually replaced by gallium-68 scan, which I know you're going to hear about, which is already replacing it in Europe. And some of you have had that scan. It's being used experimentally here at present. And then finally, the FDG PET, the standard PET scan, which is used for many malignancies, depends upon the metabolism or the rate of growth of the tumor. And now in ordinary cancer, carcinoma, the tumors are growing much more rapidly than with carcinoid or neuroendocrine tumors, so they require more energy Therefore, they gobble up and use sugar and glucose in the body for their energy source. And if we take fluorodeoxyglucose, which is FDG, to which the radioisotope is attached, that is used for the PET scan, and administer that, then the tumor will attract and use extra glucose, extra sugar, and more the isotope will register there, and it'll show on a scan. But usually neuroendocrine tumors are more sluggish and slower growing, and so they don't take up this material, and they won't register on the scan. And if somebody is relying upon the FDG PET scan to make the diagnosis, they're going to miss it. On the other hand, if a neuroendocrine tumor does register on a FDG PET scan, it suggests it's more aggressive than the average. So I use it to help tell me about the aggressiveness, not to make the diagnosis. And here are some other comments. The EUS, endoscopic ultrasound, is very good for visualizing lesions in the pancreas because this probe is pushed into the stomach as part of an upper endoscopy, and only the thin wall of the stomach is in between the tip of the probe and the pancreas. And so that instead of doing it from the outside of the body, you can do it this way and pick up little tiny lesions. What you do about them is another issue. That we have the wireless capsule or pill camera where you swallow this pill and it can take pictures internally and register them on a monitor outside the body, and so small lesions can often be seen that way better than any other way. And then we have now the double balloon endoscopy technique, which also sees lesions inside the gut, but can biopsy them, unlike the pill camera. And here, very quickly, are some samples. This is a standard Octrio scan. The black or dark stuff is the increased focus of isotope. The big round one at the bottom is in the urinary bladder, which is where the material is excreted and doesn't represent a tumor. But up above in the liver are some of the heavy black spots, and these are metastases. You'll hear more about this. And then the gallium-68 scan on the left side is the Octrio scan, and on the right is gallium scan, and look at all the dark spots there are. Much more sensitive, shows them better. You'll hear about this later on. And now here, one is a CAT scan, and one is a MRI, and you see in the liver the structure on the left side, and both views of these circular areas, which are metastases. And they're seen in both of these techniques. And here, an endoscopic view, and this is a small carcinoid in the stomach, the little lesion there, magnified. That's probably about half a centimeter or so in size. And here is an angiogram done by a catheter that was placed in through the arterial system, threaded under the fluoroscope up into the blood circulation that goes to the liver, and branches that go to tumors were injected with a dye contrast, and it outlines those big round cannonballs you see are vascular tumors. And this technique is used for injecting radioisotope-bearing particles or chemotherapy targeted right to that so-called SIRT, selective internal radiotherapy. And here is an endoscopic sonography of a rectal carcinoid, a little small one. At the bottom of the picture, you see a little gray area, and then in the insert you see a little irregularity. That's a very small carcinoid. and it's the capsule. And then finally, a word about treatment. It's divided into two types, supportive, or three types. Supportive treatment, like octreotide, surgery of a wide variety, and then anti-proliferative chemotherapy, radiation treatment, and so forth. You'll hear more about all of these. And at this point, I think I'll terminate what I've had to say.